Okay, well, looks like we lost some people at lunchtime yet, or they may be coming back. We'll see what happens with them.
I'm afraid if there is food poisoning or something.
Okay. Okay, well, what we had been asked to do is to have somewhat of a more extended discussion in 4 areas, but we thought that we would probably replace the one on neurocognitive disorders with a discussion on addictive disorders today because of a somewhat greater interest in the area. But what I will do briefly is go through some of the, just a few additional points on schizophrenia disorders, depressive disorders, trauma and stress disorders, and then we had reserved some time for some more discussion, in each of these areas. So let me just introduce them briefly, and then we can have some additional discussion. So certainly for those of you involved with inpatient psychiatry dealing with schizophrenia, the key issue is removal of the Schneiderian kind of first-rank symptoms of bizarre delusions and hallucinations as a single criterion for getting a diagnosis of schizophrenia. And the rationale was that there have been a number of studies trying to distinguish between bizarre and non-bizarre delusions, and they really were not very successful in having any reliability of clinicians being able to adequately do this. And bizarre delusions, such as they are, can also occur in some of the mood disorder, affective disorder psychoses as well. So that was a major change. And then the additional requirement to have 2 required symptoms to meet criterion A was important because of the possibility that you could have a non-psychotic schizophrenia. I mean, you could have somebody who is just having the motoric kind of symptoms like catatonia and the negative symptoms, and you would have what the Soviets were able to achieve of non-psychotic schizophrenia or sluggish schizophrenia, ideally. You don't want to have that. You want to make sure that there actually is a psychosis present for a sufficient duration in order to diagnose the individual as having schizophrenia. And this was really an oversight in the DSM-4 that I think people did not really realize it when they just required any 2 of 5 and didn't insist that one of them needed to be one of the psychotic symptoms in the first 3 of delusions, hallucinations, or disorganized speech. So I think and then the other issue was that the subtypes were removed, and they were shown to have very poor reliability and validity. They failed to differentiate one from another, even though things like paranoid schizophrenia became, a major subtype. But what has happened over time is that people simply shift out of paranoid and into an undifferentiated or catatonic, rarely. But nonetheless, the feeling was that the subtypes did not really help. And what was more important, and I'll show you this a little bit later, was having a dimensional assessment of psychosis that gave somewhat of a dimensional assessment of not only the 5 symptoms, but also aided, you would also get an assessment of mood, of mania, and of cognition, particularly some of the cognitive impairments that are associated with schizophrenia.
Does DSM5 still recognize residual schizophrenia?
Pardon?
Residual schizophrenia. Residual type.
Residual type.
Residual,
Not per se. No, I mean it does have. Well, it does have some specifiers. Yeah, in the specifier level.
Can we just ask you before, for each topic, just before going to the other?
Okay, sure.
So that we accumulate.
Okay, let's get the mic then, so you can for any questions, you can have them recorded. So before we go to schizoaffective disorder, we want to finish up with schizophrenia.
Regarding what was known as simple schizophrenia, I know it is not in DSM-4, but it is found. And what about this type of diagnosis in DSM-5? What will be considered, especially after, as you mentioned, that delusion and delusion, hallucination, or thought disorganized speech, it should be, so we cannot diagnose by the other two themselves now. So cases like what is known by other classification system, like simple schizophrenia, what will be, what place will be here?
Well, I'm not sure if you would find these individuals qualifying for schizotypal personality disorder. Okay, because we have put schizotypal, in the, we've registered it in the schizophrenia spectrum area as well as in the personality disorders. So that, and the early kind of genetic work that C. Marchetti and others did with the Danish adoption studies, where they found that the whole spectrum, which included from schizotypal personality, which the ICD listed as just schizotypal disorder, as opposed to calling it a personality disorder. And so that's considered really part of the spectrum, even though it's defined, in the personality disorders. So more of the, it's possible to have more of the withdrawn, bizarre thinking types of symptom presentations in the schizotypal personality range, but simple schizophrenia per se, non-psychotic schizophrenia, is not really possible in the DSM-5. Okay, now schizoaffective disorder was one of the most unreliable disorders in DSM, because what would happen is that it was defined on an episode basis. If somebody had a combination of mood and anxiety and psychotic symptoms at the same time, they could be diagnosed as schizoaffective. However, they would go on, and over time they may lose the mood symptoms and really just present with psychotic symptoms, the 5 criteria for schizophrenia. And what we thought would be important to try to improve the reliability of this kind of bridge diagnosis between the affective psychoses and the and schizophrenia psychoses was to basically require that at more than 50% of the lifetime of the disorder would be associated with significant mood symptoms, as opposed to at any point in time on more of an episodic basis. So that will diminish the prevalence somewhat of schizoaffective disorder and will increase to some degree the prevalence of schizophrenia. But I think what we are hoping is that over time people will use this, the 8 different domains in the, that I'll show you shortly, to describe on a dimensional basis the symptom characteristics of schizophrenia. And there was an actual proposal initially to eliminate the term schizoaffective disorder altogether, and to just, because it is considered so unreliable, and to focus just on a course of illness and on characterizing the syndrome on the basis of dimensions that I'll show you in a minute. Okay, and as I had mentioned before, catatonia now is not seen just as a subtype of schizophrenia, but as a specifier for neurodevelopmental, psychotic, mood, other mental disorders, and for some medical conditions besides, in which catatonia is present due to another medical condition. And This was, the concern was that catatonia was being under-recognized, particularly in psychiatric disorders other than schizophrenia and psychotic mood disorders. And it was apparent that inclusion of catatonia as a specific condition that can apply more broadly would help address gaps in treatment of catatonia. And again, the clinical concern was that people saw it as just a form of schizophrenia and would apply antipsychotics to it, which could be life-threatening because the usual treatment for acute catatonia is really benzodiazepines or ECT. One doesn't want to make the mistake of thinking it's just another psychosis. So that's the reason for really breaking it out. So these are the diagnosis-specific severity assessment symptom domains for schizophrenia and the other psychoses. You'll see that you have the 5 criteria: hallucinations, delusions, disorganized speech, abnormal psychomotor behavior, and negative symptoms, which included the restricted emotional expression, avolition, or apathy, and then added impaired cognition, depression, and mania. Because these are cross-cutting domains, and the concern was that you would basically record these as not present, equivocal, present but mild, present and moderate, and present and severe for all 8 of those, and be able to track your patients on the basis, of the level of symptomatology in each of those 8 domains. So that was the strong recommendation of the work group. Unfortunately, we did not get this put into the Section 2. It is an assessment approach in the Section 3. But we're hoping that, with medical records and the like, that they will be able to capture this information, particularly if there are electronic health records. Questions?
Thank you, sir. In regard to the severity assessment, is it a subjective assessment or an objective assessment? I mean, this 0-1.
It's a subjective assessment, right? So that, we try to make it a structured subjective assessment so that you make a determination of what is mild, what is moderate, and what is severe. So that's really a clinical judgment at this point in time, as opposed to necessarily on a particular scale. Yes?
Maybe, I don't know whether I am right or not, but during the last decade, many articles started to discuss the issue regarding schizophrenia as being, well, not as a thought disorder, maybe it is cognitive disorder. And
As a cognitive disorder.
Yeah, type of there is more concern about the cognitive impairment in schizophrenia rather than the thought
Right.
impairment. And there are many articles about that. Does this new concept, it is maybe not new because if we go to dementia precox, it is maybe return back to the old concept.
Right.
But does it reflect on the DSM5 this issue, the cognitive impairment in schizophrenia? Does it reflect in the DSM5, or still it is not well expressed in the DSM5?
We debated whether or not cognition should be an explicit criteria, and finally decided that we didn't have enough evidence to just make it a required, criteria. As you may know, the pharmaceutical industry has been trying for quite some time to develop a medication that would have as an indication the treatment of cognitive impairment in schizophrenia. So far, they have really been unsuccessful with that. What was remarkable in the last decade is that, as you said, the cognitive impairment in schizophrenia was considered to be such a severe case that there were a large number of NIMH-funded studies on cognition and the development of a whole assessment battery for neurocognitive assessments. And in fact, there's a group at University of Pennsylvania, Raquel and Ruben Gur, G-U-R is their name. Raquel is a psychiatrist, and Ruben, her husband, is a psychologist. And they have developed a very good computer-assisted neurocognitive battery in which they are convinced that they can identify kind of the prodrome of schizophrenia very early in terms of the type of neurocognitive impairment that comes up. We are certainly looking at that, and in fact we had a preliminary contract with the GERS to develop a computer-assisted neurocognitive battery that we would hope to have as part of the DSM5 to differentiate between the kind of cognitive impairment of schizophrenia, which is different than the cognitive impairment of depression and of Alzheimer's disease. So we didn't get that finished in time. We think that if in fact the GERS work and others can really specify what kind of cognition it is that is most attuned to predicting the emergence of a schizophrenic disorder, that would be the way to go with elaborating the diagnosis with explicit criteria. In the meantime, it's just recommended that an individual who is cognitively impaired be identified with one of these domains, with the impaired cognition kind of specifier here that we have, on the scale of 0 to 4, so that you know which group you're dealing with that really has some level of cognitive impairment. We hope that will be helpful in the long run, and will also, particularly in large clinical databases, would be helpful for companies who are trying, and researchers, investigators who are trying to actually develop explicit interventions for individuals with these forms of cognitive impairment. Okay. So, bipolar and depressive disorders. What we have mentioned here is the inclusion of energy activity as a criterion A symptom of mania and hypomania, making explicit the requirement of increased energy and activity to diagnose bipolar 1 or 2 disorder, and improve the specificity of the diagnosis. If somebody doesn't have this symptom, they're probably not, bipolar in essence, and it's a critical kind of component of it, as is often insomnia and sleep disturbances that are often associated with it as well. And as I mentioned before, the mixed episode is replaced with the mixed features because we're concerned about subthreshold mixed states, individuals who did not meet full criteria for major depression and mania, and thus were less likely to receive some kind of mood stabilization treatment if they presented with subthreshold kind of hypomania symptoms. And yet we see these folks as being really more vulnerable for developing a full bipolar disorder, particularly when you're using high doses of antidepressant medication, which sometime will push people right into a manic or hypomanic state. So that's the reason for being able to specifically identify the specifier with mixed features. And likewise, the anxious distress specifier was seen as kind of a compromise with those who wanted to have anxious depression as a separate disorder. And in the U.S. Kind of major field trial on the STAR-D program, which was a sequence treatment of depression study that NIMH did. It was the largest clinical trial of major depression that they've ever done. And they found that although the entry criteria were for major depression, more than 50% of the individuals who entered that trial had significant anxiety symptoms, even though there are no anxiety symptoms in the criteria for major depression, and that those were the folks who were the poorest responders to all the treatments and were at the highest risk for suicide. We wanted to make sure that clinicians really adequately assess the presence and the severity of the anxiety symptoms when they have a patient with major depression. And then I had spoken about the bereavement exclusion, and this is a very important rationale in that major loss is not limited to just the loss of a loved one. And any life event can lead, negative life event can lead to a major depressive episode or exacerbate a pre-existing depression. So individuals experiencing both conditions can benefit from treatment but are excluded from diagnosis under DSM-4. And the 2-month time frame required by DSM-4 suggests an arbitrary time limit course to the bereavement that is inaccurate. Since bereavement will often affect an individual for more than a year. So we wanted to lift that exclusion. But as was mentioned previously, this caused a tremendous hubbub in the press. The Lancet had a big series of articles about it. One of my good colleagues, Arthur Kleinman, wrote in a kind of an editorial in the Lancet that talked about the loss of his wife who had died of a neurodegenerative disease and how he was opposed to this bereavement exclusion because he thought that his response was a normal response. And I had to deal with Arthur and say, this is not, we're not medicalizing normal bereavement. But what we were doing is trying to very explicitly, I guess I don't have the actual footnote in this slide, to be very explicit about the difference between bereavement and between major depressive symptoms. And we'd certainly encourage you to look at that footnote in the DSM-5. Individuals with bereavement can basically even see humor in certain aspects of the lost person's life or in their life. There are these waves of emotion that affect the individual that are not typical of depression. In many cases, the focus is on mourning the death of the lost one, whereas in major depression, it's death is the solution to their problems. It's a very different focus. And Kay Jamison, who's a very good writer, has described the difference between her own depression that she went through as having had a bipolar disorder for years, and what it was like when she lost her husband, that they were totally different emotional experiences. And so we really wanted to emphasize this in the DSM-5, but as I said, we took a lot of grief for making this change, and we hope that it will be informative for clinicians. Let me just stop and see if there are any other questions about this area. Sure.
Regarding including increased energy or overactivity in criteria A in mood mania or hypomania, can we say that there is now a shift to concentrate in diagnosing mania or hypomania to the increased energy more than high mood, although the mood disorder by itself is a mood disorder. So now is there more concentration on the energy rather than increased energy rather than increased mood? And this is to me a little bit confusing, because when we have any difficulty in diagnosis, and even it mentioned in the basis, for example, in synopsis of psychotic Kaplan, whatever, there is each disorder, it has some core symptom or core criteria, the main. And if you have confused within the other criteria and the mixing symptoms, you will go directly. Is this patient having mainly mood problem or thought problem, whatever? If you are confused, for example, between schizophrenia and hypomania, whatever, or other psychosis. So now, if there is more concentration on the increased activity or energy, more than the high mood or elation, whatever, in mania.
Well, I think there's a continued interest in euphoria and the high mood, as the sense was that is generally accompanied, with the increased energy as well. Now, can the increased energy be present in other disorders like schizophrenia and the like? In the early phases of acute psychosis, it certainly can be. Certainly there are other conditions that you can think of, and anxiety disorders where there's a lot of energy as well. But I think it was so characteristic of mania that they wanted to emphasize the physiological aspect as well as the psychological. It becomes kind of a sign as well as a symptom for bipolar disorder. Yes.
Make it more confusing. As we mentioned for a long time in the British literature, that from 10 to 15% of bipolar disorder, they have first-rank symptoms of schizophrenia.
Mm-hmm. Yes.
For a long time.
Yes, but
Yeah. This is another point. They warn us to misdiagnose excited schizophrenic as manic or hypomanic.
Mm-hmm.
But it is very confusing, actually. Do you think so, or it is now settled?
Well, I think, if you look at some of the literature on the first break psychosis, longitudinal studies, Evelyn Bromett in Long Island has done a wonderful study in this area. There's another one in Nottingham, and first break psychotic studies are really very interesting, because what happens is the initial diagnosis changes over time, and the individual can come in with what is thought to be an acute psychotic schizophrenic process, and it will end up being a bipolar disorder, 2, 3 to 10 years later, because they follow these people now for 10 to 20 years. And so there is this movement, across this psychotic disorder spectrum that's important to recognize. Again, I think it's, we're talking about a polygenic, kind of diathesis that people have of a risk state, and how it emerges into what we're now calling schizophrenia with one of the symptoms or affective psychoses. It's a different way of approaching the fuzzy boundary between these conditions, and not getting hung up on it's purely bipolar or it's purely schizophrenia, as I think we did certainly in my training.
What to say that this makes problem for epidemiological studies?
It does if you're looking at cross-sectional epidemiological studies, no question. You have to take your prevalence rates there with a grain of salt. When you're trying to determine exactly what the prevalence rates, for a point prevalence study, it's fine. This is what the expression is, and this is what the population prevalence is. But for, a lifetime or even an annual prevalence rate, you have to be a little cautious. And when we did the ECA study, this is one of the few studies that, along with the Nemesis study in the Netherlands, where there's actually, you do a large cross-sectional study and then you do a year later and then maybe 5 or 10 years later, and follow up the same individuals. You know, you see substantial changes over the course of, you know, of that year in diagnoses within individual groups, which is another clue that, you know, these disorders aren't necessarily, you know, that stable in terms of retaining their boundaries over time. Okay. So the disruptive mood dysregulation disorder, I added this, mentioned this before, that it provides a diagnosis for children with extreme behavioral dyscontrol, but persistent rather than episodic irritability, and reduces the likelihood of such children being inappropriately prescribed antipsychotic medication. The criteria do not allow a dual diagnosis with oppositional defiant disorder or intermittent explosive disorder, but it can be diagnosed with conduct disorder. And children who meet criteria for DMDD and ODD would be diagnosed with DMDD only. Now, what's important about this is that the ICD has chosen at this point in time to to not add the diagnosis of DMDD, but to simply identify it as a severe form of ODD. And that's going to be interesting because in the US, clinicians are worried about diagnosing somebody with either conduct disorder or oppositional defiant disorder because of the potential stigma attached to their kids. And one of the major concerns that the US psychiatrists had was of seeing this much more as a mood disorder and putting it in the mood disorder category, but not putting it in as necessarily a bipolar disorder because of the you know, skyrocketing of prescribing of antipsychotic medications for kids. And so that was a major public health concern that we had. You know, it hasn't been a phenomena in much of the rest of the world where there has been that increasing use of antipsychotic medication and calling these kids childhood bipolar disorder. So I understand the WHO's approach with the ICD, but it is going to be somewhat different, and we'll be following these kind of kids over time and seeing what happens to them.
Excuse me, do you recommend
Yes.
the lithium for these cases?
For kids, no. Usually the first course of treatment here would be antidepressants as opposed to antipsychotics or lithium. They're not really bipolar. There isn't a family history often of bipolar. Ellen Liebenloft at the National Institute of Mental Health is the one who really has studied most of these kids and differentiated kind of the severe mood dysregulation, which is what she called it, from the bipolar, and then also from ADHD. And so there really is a different treatment response. Some of the kids, the only way that you can control the kind of severe irritability and rage reactions that these kids would be into, just nonstop rage reactions where they would be virtually burning the house down, you know, was actually with some antipsychotic medications. But that was rare, where they had to do that. Mostly they would respond to, you know, the combination of either stimulants or antidepressants as a first-line treatment. And over time, this chronic irritability kids, with one major epidemiologic study in North Carolina, this Great Smoky Mountain study, they would find these kids would eventually turn into having severe mood disorders or anxiety disorders, but not bipolar disorder in terms of their longitudinal history. So it's an important distinction.
Do they have any EEG findings?
Any what?
Do these children have any EEG findings?
Not that has been reported, no. I mean, they've done imaging studies, they've done EEGs on them, they've done, you know, a range of
I mean, is there a place for anti-epileptics?
well, for anti-epileptics,
Yeah.
yes. No, I think that as mood stabilizers, they may very well use some of the, you know, Depakote or Lamictal, you know, type of medications. They always worry about Depakote or, you know, in kids, particularly girls with polycystic disease and so forth. So you have to be careful with the side effects of all of these medications. Okay. So I'm going to just take a couple minutes here with the extended, with trauma and stress disorders. The number one disorder in this area was reactive attachment disorder. What was found is that there are really two distinct subtypes where attachment is a problem in kids. In one case, you have the kind of withdrawn effect of kids who won't attach to a parent or anybody. And then you have the disinhibited social engagement disorder type in which they attach to anybody. You know, they'll see a stranger walking down the street and they'll try to attach the person, and the kids are constantly, you know, running away, trying to find somebody who will provide some positive feedback to them. And yet it's still it's over time, it's a very difficult, you know, child to establish some kind of normal human relationship with. And so they're both considered, you know, a form of reactive attachment disorder, but it was thought very helpful to focus on the DSED, or disinhibited social engagement disorder, is more similar to the ADHD and disruptive behavior disorders, and as opposed to the reactive attachment disorder, more similar to depression and other internalizing disorders. So for those in child psychiatry, this is an important distinction. The stressor criteria I've already mentioned. In criteria A, we reduced criterion A2 because direct and indirect exposure to trauma are still reflected in the criteria, but A2 is not well supported by data, rarely endorsed by military and other professionals who otherwise would meet full criteria for PTSD. So that's a significant change. And then the 4 symptom clusters: intrusion symptoms, avoidance symptoms, negative alterations in mood cognition, and alterations in arousal and reactivity. The last one really includes, you know, individuals who suddenly get involved with a lot of altercations and fighting as well. And that kind of behavior was not previously recognized as a part of PTSD. The avoidance numbing, which was a cluster, is divided into 2 distinct clusters: avoidance and persistent negative alterations in cognitions and mood. And this was based on confirmatory factor analysis that suggests that the syndrome is best conceptualized by 4 factors rather than 3. And what's happened, though, is since we published DSM-4, there have been, you know, I think 3 or 4 new factor analyses that say it should be a 6-factor study, and the last one I reviewed was a 7-factor analysis that best describes how you can cluster symptoms in order to focus treatment on subgroups within the syndrome. So that becomes an ongoing kind of area of research, and this is one of the most highly researched areas, you know, in the DSM. we'll be interested to see if there's enough evidence to support changes in the diagnostic criteria in the next revision of DSM. And then separate criteria are added for preschool age children, 6 years and younger. And the DSM-4 criteria were not developmentally sensitive. For instance, young children are limited in their capacity to describe cognitions and internal experiences. Numerous studies indicate that children exposed to trauma can exhibit significant anxiety and other forms of distress that warrant treatment due to the inadequacy of the adult criteria. We've added some more child sensitive criteria for the preschool.